emergency, call 911. 28-year-old male, crush injuries.
No pulse?
Clear?
According to the American Stroke Association, stroke is the fifth leading cause of death and continues to be the leading cause of disability in the United States. Research conducted by Emerson et al. Suggests tPA is beneficial in decreasing the risk for disability and mortality in patients with acute ischemic stroke. However, tPA is not consistently administered due to time limitations of the medication and lack of accessibility to a stroke unit. Our PCO question is the following. Do ischemic stroke patients have improved outcomes when tPA is used? We have witnessed the life-changing capabilities of tPA in clinical and work experiences. This topic piqued our interest when discussing stroke-certified versus non-stroke certified hospitals. We have created two ischemic stroke scenarios. Through this demonstration, you will see how hospitals that are stroke-certified lead to improved patient outcomes by early tPA intervention compared to non-stroke hospitals. Patient arrives to a non-stroke center on a very busy day complaining of a headache and some weakness. As the patient sits in the waiting room, the time goes by. It is now about 3 hours since the initial onset of symptoms that brought the patient to the emergency room. The patient sits there patiently waiting for the nurse to come get him and take him to a room. Once in the room, the nurse takes a history and conducts a detailed and focused neurological assessment looking for signs and symptoms of stroke. As the nurse conducts a neurological assessment, she then moves on to use the National Institute of Health Stroke Scale, also known as a NIHSS, but given that this is a non-stroke hospital, she is not too sure on how to grade it. She collects the results and sends it off to the doctor, who will come in shortly to talk to the patient, do her assessment, and come up with a plan. The doctor comes in, does her assessment, gathers more information, and determines that the patient should get a head CT to rule out stroke. As a result from the CT scan come back, it is determined that the patient is suffering from an acute ischemic stroke and needs to be transported out to a specialized acute stroke center. As we await for transport to arrive, time keeps on ticking, and this places the patient at risk for increased and negative outcomes, including disability and or mortality. We will now shift our focus to a stroke certified center. As the patient arrives to the emergency department complaining of a headache and weakness, immediate recognition by the triage nurse and staff leads the patient to getting roomed immediately. The stroke team is activated and they are now all at the bedside. The doctor puts in orders, including lab work to draw a CBC, a chemistry, and to check a PT and ANR. The immediate intervention is a head CT scan to rule out an ischemic versus a hemorrhagic stroke. As the team waits for the CT scanner to become available, a consult with neurology and the emergency physician leads to an in-depth medical history taking to make sure that the patient is eligible to receive tPA if a ischemic stroke is identified in a CT scan. tPA is administered and we will give you an in-depth view of what is going on internally within the blood vessels. tPA converts plasminogen into plasmin, and that creates a clot-busting effect which helps reintroduce perfusion to the affected area. From our literature review, we have come up with the following recommendations. Increase the amount of stroke-certified centers, education of all staff on early recognition of stroke, creating a stroke team, and ultimately the most important is community education on early recognition of stroke so that positive outcomes can be obtained.